Welcome back, everyone. We have reached that time of night with Dr. Joyce O'Shaughnessy in the wings here. I want to give a big shout out to her. Thanks for doing all those fact or fictions. It's been so awesome and helpful through the years. And I'm going to bring her on right now. And I wanted to get you on a little early, Dr. O. How are you doing today?
Hey, April, good to be here. Good to see you again.
Thanks so
I think,
much for being. Yeah, thank you for being here. It's so awesome. This is like I was thinking about it earlier. I was like, I think you've been on every year since 2017. So you've been on
yeah,
many years, and it's so helpful to get with you and get updates. And we've asked everybody to submit their questions for you tonight. I've got a big list in front of me, and I don't want to waste any time at all. One of the first things that I want to start off with, Dr. O, is if you could give us the latest and greatest in triple negative research and trials that you've got going on over at Baylor.
sure. Well, thanks, April. Glad to have the opportunity to be here with everyone. So my own personal research is focused on metastatic triple negative breast cancer and utilizing right now we just completed enrollment to a second trial, so we've got a third one open, and it's using a medication called bortezomib, which is approved for multiple myeloma, a bone marrow cancer, to increase the sensitivity of triple negative breast cancer to chemotherapy and to immune therapy. So it's a combination of a chemotherapy drug plus an immune therapy, Keytruda, pembrolizumab, plus this bortezomib to try to increase the sensitivity of the triple negative to the chemo and to the immune therapy, and try to get people into a really excellent and hopefully very durable, long-lasting remission. So that trial's going on now for metastatic triple negative breast cancer. It's open. Anybody who needs a trial opportunity is certainly welcome to inquire. And the person here at Baylor-Sammons that you would call, his name is Jonathan Huntzinger, Jonathan, and our main number 214-370-1000. And just ask to speak to Jonathan Huntzinger. He does all of the intake and evaluation to see who's eligible for what kind of clinical trials that we have here. In addition to that, we have a bunch of other clinical trials that are sponsored by industry. You know, for example, one's very interesting called the Begonia trial by AstraZeneca. It combines their new antibody drug conjugate, quite frankly, their competition to the existing drug Trodelvy, which is an antibody protein against the triple negative breast cancer, chemically attached to a very powerful chemotherapy drug that's called Trodelvy. And this drug from AstraZeneca that's very similar to that is called Dato-DXd, and it's combined with AstraZeneca's immune stimulating therapy. It's called durvalumab. So that's a very important trial. That's for first-line metastatic triple negative breast cancer. We have an Amgen trial open, which is looking at a brand new agent. It's not in phase 1, it's in phase 2, a brand new agent that will disrupt the mitotic spindle, the cell division apparatus of triple negative breast cancers. Trying to think what else. Those are top of mind. Though then there's the first second line trial of two standard chemotherapy drugs, gemcitabine and carboplatin, Gemzar carboplatin, with or without, it's a randomized trial with or without a CDK4/6 inhibitor called Trilocyclip to increase the sensitivity of the cancer to the chemotherapy, to the gem carbo. That's a big theme in triple negative breast cancer, is to get it more sensitive to chemo and to immune therapy.
I remember the first time you mentioned that was a couple of years ago, where you were talking about that. I think that somebody stumbled across the fact that happened. Like they were doing something else, and they realized that this other chemotherapy made triple negative more susceptible to the chemo that you were putting on it, or applying to it, however you want to word it, and it made it work a lot better. And that does seem to be a common theme, is to sort of weaken those cells using one thing and then attack it with the other thing. Is that right?
Yes, that's right. It's a big, and that trial I just mentioned, the Trilocyclip, that's an IV CDK4/6 inhibitor. Those are like the Ibrance, Kisqali, Verzenio's of the world that are used for estrogen receptor positive breast cancer. Well, there's an IV form very well. It has basically has no side effects. It's given with the chemo, the gem carbo chemo. And in a phase 2 trial that I was involved with, there was a nice survival improvement. So the gem carbo worked a great deal better with the Trilocyclip. Patients lived quite a bit longer. And so there's an example of something probably working. That's only a phase 2. Now we're doing a phase 3, a much bigger trial where half get the gem carbo, half get the gem carbo plus the Trilocyclip. And so that's ongoing. But yeah, that's a big deal, is to try to just get these cancers more susceptible to immune cell killing. And that's the same thing as making them more susceptible to chemotherapy in general.
Gotcha. Yeah. I was curious as you were talking, I was thinking about, the pandemic and all the crazy stuff that's happened over the last couple of years. Did that affect or slow down y'all's progress with the clinical trials?
Um, Maybe a little, April, thankfully not much here. We never stopped enrollment. I mean, we had a period of time where um, a lot of our research staff were out ill with COVID. They couldn't come in, but it was, we never had to shut down entirely. But I would say that early in the pandemic, and it was really only in the first year or so, patients didn't travel that much. I think people felt more comfortable being at home, and they would, stay with their local oncologist, or wouldn't travel as much, going into hotels and restaurants and stuff, being out of town, going on to a clinical trial. So we had less traffic coming into the cancer center for clinical trials. That's still maybe going on a little bit to some extent, but we're getting more and more referrals now. I think we're getting up close to where we were pre-pandemic in terms of just enrollment to clinical trials.
I'm really glad that it hasn't slowed that down, because Lord knows we need to keep
Yeah.
plowing forward to try to solve for all this stuff. I wanted to start off the night because I know there's a lot of people who have triple negative breast cancer, either now or had it in the past, or really in the midst of their fight. But for those that are watching right now, can you give us a few of like the simple things about triple negative breast cancer that makes it different? Things like survival rate, the types of people it affects, things like that.
Mhm. Yeah. So triple negative breast cancer tends to affect a younger group of women in general. The average age of breast cancer is around 65, and it's younger for triple negative breast cancer, probably closer to 50 on average, which means half of the ladies are younger. And we think of triple negative as a young woman's disease, although you can be middle-aged or older and still get triple negative breast cancer. But it's the kind of breast cancer that women get, generally speaking, when there's an inherited mutation, such as BRCA1, PALB2, and a host of others. With BRCA2, you can get triple negative breast cancer, although women tend to get ER positive breast cancer. But triple negative tends to go with more of hereditary forms of breast cancer, particularly in the young women, let's say 45 years of age or younger. But besides genetic predisposition, other factors that can increase the risk of triple negative breast cancer are, interestingly, young age at first pregnancy and having multiple pregnancy. It's weird. That's the opposite of estrogen receptor positive breast cancer, where this earlier you have a child and the more children you have, the lower the risk of breast cancer. Lack of nursing. Lack of nursing increases the risk for premenopausal triple negative breast cancer. There's some evidence that maybe low vitamin D levels might increase the risk of triple negative breast cancer. That's a little softer.
I'm glad you brought that up. Sorry to interrupt you, but I had on the list here, somebody earlier brought up that they had heard that taking vitamin D might help lower their risk of recurrence of triple negative breast cancer. So you're kind of touching on that right now, but you said it's just a very, very slight amount, right?
Yeah, we did a nationwide evaluation of vitamin D levels as part of our US Oncology Network. It's a shared electronic medical record, so it's 15% of the country's cancer population. And we looked at vitamin D levels, low vitamin D levels, and where in the country they were happening and what kind of cancer was associated with that. And we found that lower levels in the southern part of the US, which is ironic. You would think in the north where there's less sun, but actually it was in the south. We had in our nationwide database And it was associated with increased risk of the kind of breast cancer that patients got who had lower vitamin D levels tended to be a little bit more enriched, not entirely by any means, but a little higher chance of getting triple negative breast cancer. There was a study published. Have not published it yet. The manuscript's written but not published yet. But Dr. Pam Goodwin published some years back now. She had this longitudinal cohort of patients which she had followed for decades, and she happened to have blood from them like the day they were diagnosed. And she looked at those who had low vitamin D levels, and they had a worse prognosis. The cancer type that they developed when they were diagnosed with a low vitamin D had a worse prognosis. Now, it was before we even like focused fully on triple negative breast cancer. So there wasn't detail, as I recall, about ER positive or ER negative, but I do remember it was higher stage. It tended to be like more node positive, more stage 3. Now, it's a little tricky because vitamin D levels are lower in women who are obese, probably because vitamin D is stored in fat. And so it's sequestered in fat. And so the blood levels of vitamin D are lower. And we know that obesity increases the risk for having a more aggressive form of breast cancer, and also, unfortunately, increases the risk of having recurrence of breast cancer and death from breast cancer. So it's hard to sort it out. What's obesity? What is low vitamin D? There are no data that taking supplemental vitamin D, once somebody already has breast cancer, lowers risk for getting recurrence of breast cancer, dying of breast cancer, getting a new breast cancer. So we don't have that kind of risk reduction information. But vitamin D receptors are important transcription factors in triple negative breast cancer. We got the lack of the estrogen receptor, the lack of the progesterone receptor. We do have androgen receptors. The male hormone receptor is present maybe in about 20-25% of triple negative breast cancers. We got the glucocorticoid receptor. Glucocorticoids are steroids. The stress steroids that like come out of our adrenal gland. We know triple negative breast cancers have the glucocorticoid receptors, and they also have vitamin D receptors. Now, vitamin D receptors and the nucleus of triple negative breast cancer. Now, what is it doing there? I'm thinking, it probably needs enough vitamin D, because vitamin D tends to, differentiate, make cells more normal-like. It's a normal factor. So we're only connecting some dots here. So I tell everybody to take 2,000 IU of D3 daily for life in the soft gel. That's why I say just everybody take it. Now, if you're low on D, I say take 5,000 to try to get. Now, there's no evidence that 80 is better than 30 or 35 or 40. Above 30 is normal on your vitamin D, on your 25 hydroxy vitamin D, about 30 is normal. And so if you're comfortably at 30, 35, 40, you're fine. There's no evidence that you do better with 60 or 80. So the data are weak. However, with vitamin D, it's not one of those things that we know, like avoiding weight gain. For example, we know that keeps women's risk lower if they avoid weight gain. We know walking 3 hours a week will lower the risk of recurrence and death from breast cancer. We don't know to that level with vitamin D, but there's some sort of circumstantial evidence, if you will.
Yeah, and it's every time I go for a walk during the week, Dr. O, I think about you. I'm like, I'm out here, I'm doing it, and I'm getting some natural vitamin D while I'm doing it too on the nice days. But yeah, and it's easy if you start to think about how important that is to go and walk 30 minutes a day and take that break from work. You really need it anyway. You may as well just go out there and walk for 30 minutes. It's going to help reduce your risk of breast cancer and all that good stuff. So it's awesome. It's funny about vitamin D, talking about this, and even though it's possibly not a very big component in reducing your risk, but it doesn't hurt is the point. It doesn't hurt to do it is the point. And it's funny that it's also, I know that it had been tied to like COVID, that it could be helpful with the whole COVID thing. So I feel like, maybe when I had COVID last summer, it wasn't as bad because I'm taking this vitamin D all the time.
Yeah. So, no, there probably was immune effects as well. I mean, it's one of those ubiquitous things that we have to have, and its receptors are in every cell. You know what I mean? So it's doing a whole ton of different things. It regulates so many aspects of our body. It's got to be involved in immune surveillance as well, and immune response, et cetera, for it to be really helpful in terms of reducing the severity of COVID.
That's crazy. It's pretty cool that it's all tied together like that. I say, everybody take vitamin D. Do it. It rocks. It totally rocks. We have a lot of questions coming in, so I'll try to sort through them real quick, Dr. O. I know one of the questions we had earlier today, and I have them written in order, so I'm not picking favorites, was actually from my dad. But he is looking into, I believe it's proton therapy. He has prostate cancer. Thank you. I was talking about prosthetics earlier, and I almost said prosthetic cancer. That's not going to happen. So prostate cancer. And he's looking into proton therapy right now. Do you guys utilize that at all with triple negative breast cancer?
Yeah, so we're fortunate here in the Dallas Metroplex to have a state-of-the-art proton radiation therapy center. There's one at MD Anderson as well. There's not that many in the US, but we're fortunate here. Yes, we do, Rachel. We use it when we need to kind of pinpoint radiation therapy. So for example, if a woman had breast cancer and she had either lumpectomy or mastectomy, and she had radiation like to the whole breast, maybe the lymph nodes above and below the collarbone, so this whole area has been radiated. Now she's got a recurrence on the chest wall, for example. You can't go back and radiate that whole area, so that will be removed, resected. You'll get that cut out, and then we always like to follow up with some radiation. So, or in the axilla or the supraclav, some places that there's a lot of nerves. We can't go back and do a whole lot of radiation, but we want to give some targeted additional treatment to that area that had the recurrence. We will go ahead and use the proton therapy anywhere in the body that is tricky. For example, the lymph nodes in the mediastinum, for example, you want to stay away from the big vessels in there. If a woman had a area of a brain metastasis, for example, that was near a, very, very close to her pituitary or some other place that we do not want to, injure that with generalized radiation, you can use proton therapy. So yeah, we don't really use it instead of like our breast radiation. I don't really recommend it because you can give proton over a bigger area. It doesn't have to be very, very narrowly focused. You can, but we don't have the kind of data, give me that good old 20-year data, that we have with regular radiation therapy. And you're getting the lymph nodes above and below the collarbone and down the breastbone and sometimes into the axilla. And we don't have the kind of long-term data with proton that it's gonna, get that, uniformly. And what's the cosmetic result? How much scar tissue and retraction and blood vessel death is going to occur with proton. We don't have that kind of long-term safety and efficacy data with proton. So I don't like to use it instead of, gals will come in and say, well, my cancer's on the left side. I don't want any of my heart in the field, the radiation fields. I want to do proton. I tend to try to discourage that. I don't, now with the three-dimensional modeling of our radiation therapy, everything's done 3D conformal radiation to try to stay off the heart. And it's very successful these days. A little bit of lung will get radiated when the lymph nodes have to be included above and below the collarbone and down the breastbone, but it's minimal. It doesn't really ever, result in anything concerning to patients. So I'm always like, let's stay with the tried and true. So I'm not a big fan. There's trials going on. There's trials going on with proton versus the standard radiation for a variety of different parts of the body. Now, with regard to the prostate, so that's a pretty delicate area. And I think that's a good example of a place where you'd really want to focus the radiation, as much as possible. Again, it's tricky because there are sometimes some draining lymph nodes in the area of the prostate. And again, I'm not a prostate expert, I'm not a radiation therapy expert, but that's kind of the trade-off. The more pinpoint you go, you're on purpose not radiating existing structures. So, if the radiation doctors, put their heads together, and what happens a lot of the times is, I'll refer my patients to one of our great, breast radiation oncologists, right? And then a lot of times the radiation doc will say, wait a minute, I think this is a good example where proton could potentially help. So then they'll reach out to our proton. It's Dr. Jared Sturgeon. He's the head proton radiation therapy doc here in Dallas. They'll just reach out to Dr. Sturgeon and say, hey, Dr. Sturgeon, have a look at this situation. Do you think proton would be good here? So when the radiation docs put their heads together, along with the surgeon, because the surgeons are very savvy about the anatomy and what to really make sure to cover, et cetera. If it's a team effort and people think, yeah, this would be a good place to consider proton, I think it's quite reasonable.
That's good information. I'm glad that you answered that. I know Dad's watching right now and appreciates that. Mom's watching too, so thank you so much for that feedback. I've got a question here from Angela Stevens. She says, I had low vitamin D levels for at least a year prior to my diagnosis. Do you think that might have been a contributing factor?
We don't know. We don't know for sure whether low vitamin D increases the risk of breast cancer. We don't know for sure. Like I had mentioned, we have some circumstantial evidence, and there's some evidence in the literature too that you can see more breast cancer, and particularly, in our work, more triple negative breast cancer, and in patients who had low vitamin D at diagnosis. But what our work can't say is, because in US Oncology, we're only taking care of cancer patients. So what we can look at and say is, where were vitamin D levels low? What kind of breast cancers did the women get? Did they get kind of more aggressive breast cancers? That's what Dr. Pam Goodwin had shown. But what our work can't do is say, was there a higher incidence, a higher risk of getting the breast cancer in the first place? Because in women where the vitamin D is low, for example, you go to look at the South, for example, and you take women who have low vitamin D levels versus those who don't. Is there a higher risk of breast cancer in those with a low vitamin D level? And so I am not aware of data to that effect. So I'm not aware of good data that suggests that low vitamin D increases the risk of breast cancer, because if that were the case, we would have big public health educational initiatives, and we would be talking to our patients all the time about, hey, vitamin D is a preventative for breast cancer. We can't really say that.
Right. It's not to that point for sure, it sounds like.
Right.
Yeah, that's great information. Another topic that came up earlier, Dr. O, was with Courtney Phillips Long, who was on right before you. She had heard something about, and I'm gonna say the name wrong, metformin. Is that right?
Yes, metformin. Yes.
Okay, and that has some effect on preventing recurrence. Can you speak to that?
Yes. Well, we were a little disappointed about that, because at the San Antonio Breast Cancer Conference in December, Dr. Pam Goodwin was the principal investigator on a very important trial. I think it's called the MA32. I think it's called, that's the name of this clinical trial. You could look it up, where women with ER positive breast cancer, HER2 positive breast cancer, or triple negative breast cancer. And these were women who were kind of either, they weren't insulin dependent diabetics. They had high glucose levels, women really at risk for diabetes. So women who are tending to run high glucose. When you run high glucose and you're not on metformin, it means your insulin levels are high. Insulin is our enemy. When you have breast cancer, insulin is a very strong growth factor for all different kinds of breast cancer, which is why I talk all the time about avoiding weight gain. Don't gain, because that increases insulin, and it's always on. It's kind of like, taking, if you're ER positive, to take a whole bunch of estrogen, because estrogen drives ER positive breast cancers, but so does insulin. Insulin drives all types of cancers, and that's why postmenopausal weight gain increases the risk of breast cancer recurrence. That's actually well established. And postmenopausal weight gain increases the risk of getting breast cancer. And weight gain, it's not just estrogen. A lot of more fatty tissue, I got more estrogen, true, but it increases the risk of triple negative breast cancer too, which is driven by insulin, among other things. So We don't want to gain. So metformin lowers insulin levels. It's a diabetic drug. It's a diabetic drug because you have the high glucose, and then you've got the insulin levels that are high, trying to drive that glucose into the cells. And when we eat too many calories, let's say I need 1,500 calories to maintain. If I eat 1,800 calories in a day, what am I going to do with that extra 300 calories? I don't need it. I didn't expend it. So that's what insulin does. Insulin turns that extra calories into fat for a rainy day, for when we're starving. We need that extra calories stored as fat. So eating more than we expend in a day raises insulin. Sedentary lifestyle raises insulin. Heavy sugar loads raises insulin, and weight gain raises insulin. And so she did this trial about lowering it with metformin. So the ladies finished up their chemo. If they were going to get chemo, if they're ER positive, they're on anti-estrogen therapy, and they were randomized to take metformin or not. I don't forget it was placebo or not, but anyway, metformin versus not. And unfortunately, the overall trial was negative. It did not reduce the risk of breast cancer recurrence. And they looked at the ER positive, where we know insulin plays a big role. Nope, lowering insulin did not lower risk. They looked at triple negative. Nope. Now in HER2 positive, that's where they saw a signal. They saw a signal that metformin lowered the risk of recurrence in HER2 positive. But then they did a very clever thing, clever people. They said, there is this polymorphism. There's this genetic difference among people, like blue eyes and brown eyes, for example, nothing abnormal, but there's this genetic difference. We don't even know what the genetic difference is doing. It's a blood test. If you go in and you look at our genetics, there's all kinds of variations in our genes. Okay. We don't even know what some of them do, but they have found in studies in diabetics that certain diabetics that have this one polymorphism, it's called, genetic variation, did great with the metformin. It worked like a charm. And then people that didn't have that that variation, the metformin didn't work as well for them. And so they went into the HER2 positive patients, and they found that it was the patients with HER2 positive breast cancer that had that variation that made the metformin work better for diabetes. It was reducing the risk of breast cancer recurrence by about 50%. It was
wow.
good.
That's like finding the treasure chest almost, or something,
Exactly.
It's like, that's so cool.
Isn't that cool? Isn't that cool? Research. But the thing is that getting that test done is not available just as standard care, because we don't tend to test for things outside of research studies that we don't even know exactly what they mean. You know what I mean? So we can't yet, you can't send your blood to 23andMe, for example, to my knowledge, and see if you have that genetic polymorphism or not. So I hope they're going to do a follow-up study, lowering insulin. There's other agents that can lower insulin as well, such as candesartan, which is a SGLT2 inhibitor. There's a bunch of them. And I hope they're going to do a follow-up study with agents that can lower insulin in the context of that polymorphism, although that really was making metformin work better. So the bottom line is, unfortunately, there's no reason to take metformin to lower the incidence of breast cancer recurrence. Now, metformin, when you lower insulin, it's easier to lose weight. So if people need a jump start, let's say people are running kind of high glucose levels, which happens with overweight or obesity. And so they're running kind of high glucose, want to get that down. Metformin's a good choice because it'll get the sugar level down. It'll lower insulin, which is a growth factor for cancers, and it will help with weight loss. So metformin's a good choice if people need a drug to lower blood sugar, but not just in and of itself, not just taking it to reduce the risk of breast cancer recurrence.
Gotcha. And I mean, we're getting a theme here, everybody. It's the weight loss and making sure that you're not obese and staying in shape and all that stuff. That's the best way to reduce your risk of breast cancer and to reduce your risk of recurrence, or one of the ways. You've got several that we're going to for sure hit on here in a little bit. Gosh, I have so many other questions. Okay, so we have a couple more here. I'm going to make sure I know we are running close on time. I hope maybe you can go a couple of minutes over. Somebody brought up earlier that their oncologist suggested not using a cold cap because they felt that it wasn't a good idea to slow the blood flow in your head.
Yeah,
Can you give your opinion on cold caps?
sure can. Yeah, this has been really well studied. Actually, I'm very comfortable with cold cats. I don't have any concerns whatsoever. So there's the scalp, and then there's the skull, the bone, and then there's the brain, right? And so cold caps theoretically could reduce blood flow theoretically to any of those, and therefore deliver less chemotherapy to brain, skull, and scalp. Okay, so it turns out that the one that would be most important would be the brain, because the brain chemotherapy is necessary to kill off cancer cells that have the capability of getting in the brain, or even microscopically, they're already in the brain. So the only time scalp cooling could theoretically harm somebody is if not enough chemo was going to get to the head where the chemo is known to work to kill off any microscopic cancer cells that are there. Okay, so triple negative breast cancer, HER2 positive breast cancer, you say, oh, I don't really want to be clamping down the blood vessels because I don't want to, take the chance that I'm not going to deliver as much chemo or Herceptin or Perjeta to the brain. Now, there's no evidence whatsoever that you really end up cooling the brain with the cold cap. We struggle to cool the scalp. It's hard to cool it. It's hard. Even with the scalp cooling, people still lose 25, 35, 40, 50% of their hair, because it's even hard to cool the scalp appropriately. So I'm not worried that we are decreasing blood supply to the brain. So I'm just simply not worried. I think this doesn't alter it at all. Now, with regard to the bone and the scalp, it turns out that mets that go to the scalp in particular, for sure, scalp mets happen very, very late in women with ER positive metastatic breast cancer that's already metastasized for years. Scalp mets are a consequence of other mets in the body, other mets traveling to the skin, and chemo doesn't do a darn thing for it. It's really treated with hormonal therapy. So cooling down the blood vessels, so triple negative doesn't go to the scalp, for example, HER2 positive doesn't go. It's ER driven. It's really the non-aggressive variety of ER positive breast cancer, not the fast growing variety, which can respond to chemo. It's the slow growing variety of ER positive that metastasizes to the scalp. And so chemo doesn't really work for those kind of cells. It's anti-estrogen therapy that works, but it's a much later. Scalp mets are uncommon, very uncommon, and we just see them late when somebody's had metastatic ER positive breast cancer for a long, long period of time. And I think of the bone similarly. First of all, I really don't think that the scalp cooling is going to be substantially decreasing blood supply to the bone. I really don't think so. But breast cancers that metastasize to the bone in general are ER positive and not very well killed off, if at all, by chemotherapy. And so I get it's just not been an issue. Furthermore, research in terms of the scalp cooling's been around for 35 years, and there have been long-term studies done over several years after scalp cooling to see if it increases the risk of scalp mets. Not a whiff of possibility on
so
that.
good. Yeah.
So I just don't think it's an issue.
Yeah, it sounds like it isn't. It's good to know too, Doc, because when Courtney mentioned that earlier, I was like, or maybe it wasn't Courtney, it might have been Angela. But either way, when they mentioned it earlier, I was like, oh gosh, I know lots of people who've done the cooling cap, and it got me a little concerned about them. So thanks for giving your opinion on that and setting the record straight. for that. It's so important. I didn't want to miss a couple of other questions. I'm sorry to have interrupted you there.
That's okay. You're
During one
good.
of the other interviews, somebody brought up that they wish that rather than doing mammograms, that we would do MRIs annually. Are mammograms enough? I know now the 3D mammograms are pretty killer.
Mhm,
They're pretty
mhm.
awesome. So
Yes.
is it necessary, or do you think that do you have any issue with the mammograms not being enough at any point in time?
The 3D MAMs are way better than even the old digital MAMs in terms of the dense breast tissue. But there are still ladies, April, that even with 3D MAM, it's very, very dense and it's not ideal. It's less than it used to be, but there's still real tough density on 3D MAMs, and particularly in the very young. MAMs just don't even work in ladies 35 and under. It doesn't even work. It's just the breast tissue is way too dense. So, that's why if somebody's got an inherited mutation, a germline mutation, we got to start screening early. We don't even touch MAMs until they're over 30, 35. So there still are ladies that if they got totally dense breast tissue, it's not unreasonable to consider an MRI, and certainly not if there's a family history, of breast cancer. But that's why we don't start screening till 40, because by 40, most of the time the breasts are not that dense, but there's still a small fraction of people, women, that even 3D is not ideal. Things are missed.
Where
Now
do
the other,
where do
go ahead.
ultrasounds fall in all the screening?
Not so good. It's not a good screening tool
Mm.
because it's too laborious to get all over the breast. Laboriously going over every millimeter. It's not a good screening tool. April, it's good to go look at a specific area that you're a little worried about on an MRI or a MAM or something. Now, just because ladies get MRIs, for example, let's just say annually, because they're very high risk, they still need MAMs, because MAMs will pick up microcalcifications better. And you'll be able to see these calcium specks that could signify precancer, DCIS. So they actually complement each other. So very high risk ladies need one of each every year.
Wow, really great information. I've actually never had MRI. I had ultrasounds whenever I had fibrocystic breasts, and I was going every 6 months, and that's where we caught mine earlier. But then they did a mammogram, right after that, and biopsy and whatnot. And so it worked, and it's good to know because I know there's an organization out there called Are You Dense, that really tries to help out women with dense breasts to make sure that they're getting proper screening. So hearing everything that you had to say really speaks to that whole thing. I had a question as we were talking, actually. Like I said, one of the recurring topics we have here is about making sure you stay in shape, you're exercising, you're not gaining weight after cancer, or all these things that can increase your risk for breast cancer. Are you aware by chance of any resources of groups that specifically work with women for exercise or nutrition that have had breast cancer?
Um, you know, I know that the YMCA has a free type Live Strong program that offers some free access to trainers and exercise equipment. I'm not sure about the dietary part of it. I haven't heard, for example, that Weight Watchers, which would be so great. Wouldn't it be great if Weight Watchers had a program for cancers where obesity makes a difference? Endometrial cancer, renal cancer, there's a lot of different cancers where obesity makes a difference. I haven't heard of that, April, but what I do want to mention, and again, we need a randomized trial on this in women with breast cancer who are overweight or obese and have somewhat high blood sugars, which goes along with being overweight or obese. But these new glucagon-like peptide 1 receptor agonists, GLP-1RA receptor agonists, such as the semaglutide. There's several of them out there. Several drug companies have them. Like that's the Trulicities of the world. Wegovy, and they come either pills or they come once a week subcutaneous injections under the skin. Well, they were approved initially for diabetes. They're diabetes drugs, but then they found in the clinical trials that they can cause a very sustained up to 15% or more body weight loss. Talk about a great jump start, right? And now there's clinical trials now specifically for obesity, and they're positive. They're in the New England Journal of Medicine. Now we got FDA approval, but they're very expensive. And the insurance companies have not really embraced utilizing them yet for obesity. I'll tell you, these are game changers. Thankfully, we finally have something that works really well for weight loss and sustained, and we just need to get it out there now for women who are, quite overweight or obese. We don't have a clinical trial in breast cancer showing that these agents would lower the risk of recurrence. I'll bet my money on that one, but we don't have that yet. But I know a number of my patients are on these medications already because they need something for diabetes. So if your glucoses are running on the high side, you don't have to be like frank diabetic, but they're kind of running on the high side and you need a med, maybe your doc can get you that med. And then weight loss, if you need the weight loss, lower the weight loss, it's great. And that really makes it easier to keep it off. So I think, honest to God, April, as you and I have talked about before, we don't have a lot of good resources to, it's difficult to lose weight and to keep it off. It's difficult. And I think it might be near impossible unless people are exercising at the same time and keeping the metabolism up, etc. But these drugs are game changers. And just stay tuned. It's gonna come. We have such a huge obesity problem in our country anyway. You know what I mean? So we have got to get some solutions. And I think these drugs are really gonna help a lot.
Wow, that's great news. I can't wait to hear an update next year, see if anything's changed in that arena. That'd be awesome. And in the meantime, Doc, I'll work on that partnership with Weight Watchers, okay?
Okay, well,
that's on me, okay? I will work on that. I'll work on some nutrition thing. We'll get some programs going. Then we'll have something to direct these ladies too that struggle with this, who've had breast cancer, that really needs to get in shape and help reduce their risk. There should be something. So if there isn't anything, I promise I will look into that. It's on my list now. We had a question come in. I think this should be the last question, and then we'll wrap it up with our normal kind of all the different things that can reduce your risk of breast cancer. But this comes from Courtney Long. She says, what do you think the long-term effects of chemo to the brain are? We all seem to suffer from brain fog, and that is more from hormonal issues from chemo or just chemo itself?
Thankfully, I think the news is good there. They've been now long-term studies showing that chemo fog, that no question happens during chemotherapy. There's no question there's chemo fog, or even some chemo brain afterwards, where oh my God, I can't, calculate, 10 rows of numbers in my head like I used to be able to, that kind of thing, that it goes away. It does not stay. Most of the drugs that we use don't really have ill effects on the brain. They used this when they first started studying this. They found that the old-fashioned chemo that we don't use anymore, called CMF, they enough of that got into the brain that it caused the most in the way of the chemo brain in terms of decreased ability to do these IQ tests they put the people through, or the cognitive tests. But we don't use that. But the most recent data really show that the effects that you can show of decreased cognitive function during chemo, immediately after chemo, 2 years later, gone. Now, however, the hormonal effects of chemo are really, really major. I mean, it can take somebody who's 35 years of age and put her into permanent menopause. So now she feels like she's a 55-year-old, and the problem is that lowered estrogen over time for us postmenopausal ladies has a profound effect on our brain function. The word finding, oh my God, what's that person's name, or what's that word, even some attention. It's not really a memory issue, it's attention. We're not as able to focus as well. Now, it's like everything else. Use that muscle or we lose it, right? We got to keep our brains going here. You gotta, we all know this. We all know these people that are 85 years old and they're working like they're 30 years old, and they got the brains of a 30-year-old because they use them all the time. You know what I mean? So it's really, really important. But so there are profound hormonal effects. We're not sleeping, and we're not. And I'll tell you, after the menopause, you can't get away with less sleep than you need. You can't get away without exercising. You just can't get away with it. You have to have that help in order to keep the brain going.
I met with a guy recently who was in his 90s, I think, and he was just sharp as a tack. And I was like, how do you stay so on top of it? And he's like, I do puzzles every day. And I'm
Yeah.
just like, wow, okay. So everybody, this is Wordle. So be sure and check out Wordle. That'll help your brain. And
Stuff.
and
It's
I
not too hard. It's not too hard.
no, yeah, it's right. And it's funny because I think a lot of us who've been through breast cancer and had chemo and stuff, that we sort of use that as an excuse a lot as we get older. I still use it, but I'll try to stop. But where you're like, oh, I can't think of this word as well as I used to, and it's probably age and menopause
Low
and all that
estrogen.
different stuff.
Yes.
Yeah, all that. So I'll try not to blame that anymore.
It's
I'll
okay.
do
You
my
can blame
best.
chemo. It is blamed for everything. So it's okay.
Yeah, it's okay. Everything. All
Everything.
right. It looks like we don't have any other questions, and we got through everything. The last thing, again, if you don't mind, I know that Mary Kay is coming up next. She's going to be our next guest. So Mary, just hang tight. We'll be right with you. But if you don't mind, Dr. O, if you can do that same thing you always do, just give us the rundown of those things that each person can do out there to reduce their risk of breast cancer or reduce their risk of recurrence of breast cancer.
So reducing the risk of getting breast cancer, certainly a woman who's been has a very strong family history or has had a biopsy which shows atypical cells, for example, or lobular carcinoma in situ, a precancer, they can take anti-estrogen medicines. You can take tamoxifen. You can take an anastrozole, which is a Arimidex. You can take that. Those are very profound and very low dose tamoxifen, by the way, tiny little dose of tamoxifen, no side effects, can reduce the risk. So there are hormone anti-estrogen pills that can really reduce the risk a lot. Not drinking much reduces the risk. More than one drink a day raises your risk of getting breast cancer. So don't drink that much. Don't sit on hormonal contraceptives all your life. Don't sit on whether it's oral contraceptives, whether it's Depot, Provera, whether it's NuvaRing, whether it's Mirena IUD. Don't sit on hormonal contraception for decades and decades. Just take it as long as you have to have it and get off of it, because those things like the Mirena, for example, constant low dose in the body of this progesterone-like drug, it increases the risk of breast cancer. It's only a small amount, but the thing is, year after year after year, for decade after decade, too much, it raises up the risk of breast cancer. Same with hormones after the menopause, particularly progesterone. Maybe not so much estrogen, although decades of estrogen too. If you have a hysterectomy, you don't need the progesterone, but decades of estrogen too is not good. That'll raise the risk too, but progesterone increases the risk of breast cancer. And so after the menopause, if people really are having a tough time, fine, take it for a few years, but don't stay on it forever. So don't interfere with Mother Nature doing her thing in terms of the hormonal milieu of our body. It's rhythmic, and Mother Nature does it on purpose, so we can clean the breasts when we have good normal periods, for example. So that's an important thing. Alcohol, like I mentioned, not drinking a lot. Postmenopausal weight gain increases breast cancer risk. Not premenopausal weight gain increases breast cancer risk. Things like nursing children lowers the risk of premenopausal breast cancer. And let's see what else. Nursing, and then exercise. There are studies showing that exercise can reduce the risk of breast cancer. And there's also a study that showed that a low-fat diet for women diagnosed with breast cancer, those that were eating a low-fat diet, they had a less aggressive form of breast cancer. So it didn't prevent the breast cancer, but it lowered the risk of dying of breast cancer. So those are some thoughts there. In terms of reducing the risk of a breast cancer recurrence, not much alcohol, less than one drink a day. It's clear that one or more drinks a day can increase the risk of breast cancer recurrence. And the more you drink, the higher the risk of breast cancer recurrence. Alcohol is a terrible toxin, and we should never have more than 2 in a sitting. If it's an all-day party, an all-day vacation, maybe nursery, but drink lots of water. You want to dilute. You don't want a heavy level of alcohol in the body. It just will irritate and wake up and aggravate sleeping cancer cells. So, and it increases the risk. It increases estrogen. It increases hormone levels because it gets them absorbed from the gut and then they get reabsorbed across our intestines and back into our bloodstream, because alcohol is a good solvent, and all the hormones in our gut get reabsorbed, and now we have higher hormone levels. And so alcohol is tough stuff. So it's fine to have a couple, 3, 4 drinks a week. That's fine, but not 2 glasses of wine a day. That's too much. Weight gain, postmenopausal weight gain after breast cancer diagnosis clearly increases the risk. I don't mean 5 pounds. 10% or more gain of body weight increases the risk of breast cancer, particularly serious for gals who are node positive. Node positive, unfortunately, there's a pretty high risk. There's some microscopic cells dormant somewhere in the body, and 10% or more body weight gain does increase that risk. And unfortunately, if it happens, you can't then lose it fast and get rid of the risk. Unfortunately, just that risk of having gained that 10% or more, really has just increased the risk, because it's exposed the dormant cancer cells to, over quite a period of time, to more insulin and more leptin and more estrogen and more hormones and things that can wake them up. And then we know that walking 3 hours a week at a moderate pace reduces the risk of dying of breast cancer by 50%. That's probably multifactorial. Walking does so many things. It helps with weight control. It lowers insulin. It increases immune function. Probably a whole ton of things we don't fully even understand. But walking 3 hours a week, or whatever people like to do, it be walking, just some moderate paced activity 3 hours a week, really reduces the risk of breast cancer recurrence. And then, of course, being adherent, taking the anti-estrogen medicines, taking the medicines that are proven to lower the risk of breast cancer recurrence. It really does help, because if people don't take them, then they've shown that the outcome is not as good as you'd expect. So those are the main things I focus on, April, because those are really kind of good data to support them.
That's such great stuff. Every time you say the one about walking 3 hours a week, which I equate, 30 minutes a day-ish, and reducing your risk by 50%, that's just so huge. And I feel like we need like a billboard somewhere for that. Every time you say it, I'm just like, I wish we could just scream that from the mountaintop. So I try to repeat that as much as I possibly can. And I hope everybody watching will repeat a lot of these things that Doc said here. And we're going to have this entire interview on our YouTube channel for people to reference, as well as here on Facebook. So Dr. O, man, thank you so much for another year of supporting us for the Triple Negative Breast Cancer Day broadcast and all the work that you're doing. I can't thank you enough. We're so blessed to have you in our lives and to have you out there fighting against breast cancer.
And thanks to Breast Cancer Can Stick It for all the years of support of that research, April. So we are using that money to do breast cancer triple negative clinical trials. So thank you. Thanks for being part of the solution.
Absolutely. And we're ready to donate some more to you here next month. So we'll be seeing you really soon.
Awesome.
And contributing more to the research and trials down at Baylor. So thank you so much again, Doc. I'll talk to you really soon, okay?
Okay, great.
Have a great night.
Thank you. Bye-bye, everybody. Bye-bye.
All right, everybody. That was Dr. Joyce O'Shaughnessy. She's awesome. So blessed to have her each year come and be a part of this Triple Negative Breast Cancer Day broadcast. And Melody K is